And we are going to have time for questions from the committee. And again, thank you very much for the report. While people are warming up, I'd like to ask both of you, being the pediatrician on the panel, one of my concerns throughout this whole process, and certainly as you guys faced back in 2003, to comment a little bit on the strength of the evidence that we have both for children, the younger children, and for women who are pregnant, because those are certainly things we're going to have to address in the DRI process.
Did you want me to address that?
Both of you, but why don't you go first, and then I think Larry will be able to as well.
As I mentioned, the numbers of studies for children was extremely small, and although we did not see a statistically significant effect of sodium reduction for children, when we did a sensitivity analysis that eliminated the poorer quality studies, we actually did see a significant lowering effect, and that was across all children of all ages, because clearly there weren't enough studies to try to distinguish age groups. As for pregnant women, there was an even smaller number of studies, and we did address that in the report. However, the number of studies was inadequate to actually draw a conclusion regarding gestational hypertension.
And we can look it up, but my remembrance is in children, there were virtually no children in the first age group, the 0 to 3. And but Larry, why don't you carry on, and then we'll.
Yeah, sure. We try to address both issues. So let me start off by saying, and I think it's important that the best studies dealing with sodium and blood pressure fix sodium intake through some sort of controlled feeding, whether it's controlled feeding study like in a CRC, or there have been a few studies that have done it in institutional environments. So this is applicable particularly to children, because the idea of getting behavioral changes is just going to be possible. You have to do it through feeding. So the best study in children was the Exeter Andover study of adolescents. It's a crossover study, and it also it was sort of and it was an institutional setting and lots of blood pressure measurements, and that showed a significant benefit of sodium reduction. And then the second study that is really interesting but hasn't been replicated was done in infants, okay? And it was a trial, I believe, done in the Netherlands, in which infants were randomized to usual sodium versus low sodium formula, and the low sodium formula, and this was associated with a significant reduction in blood pressure. I don't remember the actual values, and that was by 1 year. Okay, so low sodium formula versus usual sodium formula was better. And an interesting aspect of that study is they followed up these children for about a decade later. It was they got about 60-70% follow-up, and they still saw a persistent effect, which is really interesting. But I'll also acknowledge that it's a single study, and it should be replicated. And in pregnant women, there is less evidence, but the issue the issue that for sodium reduction in this population was really to understand its effect, as a potential cause of gestational hypertension, preeclampsia, et cetera. Not many studies. The one that I recall from some of these studies seem to be done in the Netherlands. Null effect in a behavioral intervention study. Okay. Those are but unfortunately, again, I realize that HRQ was to do a systematic report. I really like, not just because I do them, studies that really fix sodium intake so you know what is being provided, and get lots of blood pressure measurements, because the blood pressure itself is really highly variable and you need lots of measurements. And I think that's part of our problem with older studies, and that's why there's this heterogeneity. So I'm looking at more of a best evidence approach.
Excellent. So now we have plenty of time for the committee to ask both of our speakers any follow-up questions you want. So who would like to start?
I'll start with a question for Sydney on the meta-analysis. You mentioned.
Let me check. Sydney, can you hear? Because this is the remote mic.
I can hear.
Great, thank you.
Great. There's different quality of studies, obviously, that are included in these reports. It seems that in the meta-analyses that were done, and perhaps on which you based the conclusions, that these were lumped together. Like the slides you showed of the meta-analysis of forest plot of blood pressure studies, they weren't grouped by quality. And how was quality used in drawing your conclusions and doing your meta-analyses?
That's a good question. As I said, we did not exclude any studies, at least any trials based on quality. That's just typical of our practice. However, one of the elements of grade in drawing conclusions is study quality, or the combination of study quality, size, things like that. So study quality definitely counted against the conclusions we were able to draw. That would have been one element that would have decreased the strength of a conclusion. We also followed up our initial meta-analyses with a sensitivity analysis where we excluded all studies that were of low quality or high risk of bias, as well as studies that had unclear quality. Many studies were simply reported in a way that made it impossible to assess what the quality of the study was. When we excluded those studies, we actually saw very, very few differences. Very few differences in pooled outcome measures and very few differences in heterogeneity. So for the trials, study quality was somewhat of an issue, but not as huge an issue as for the cohort studies. If that answers your question.
Do you want to follow that or not? Okay.
For the, okay, so just as an example, when looking at cohort studies, there are different ways of measuring sodium. And some of them use spot urine, some of them use 24-hour urines, some of them use multiple 24-hour urines. I didn't see an analysis separating out different meta-analyses for those types of measurements.
We actually didn't do meta-analyses on the observational studies. We did a qualitative assessment and based our conclusions on our qualitative analysis.
Okay, thank you.
And that was one of the reasons. One of the reasons was that there were so few high-quality observational studies that it would have been impossible to do a meta-analysis.
Other questions?
Sydney, this is Beth Yatley. I noticed that your strength of evidence ratings tend to be lower than other studies, other systematic reviews have shown for their strength of evidence ratings. And I'm thinking particularly about a ARC review that was done in about 2013. Do you have any explanation as to why you're finding lower quality data than previous studies?
Regarding the trials, Beth, we made a decision that if there were trials that reported findings that were in different directions, if the trial findings weren't consistent in terms of seeing a decrease in blood pressure, we automatically downgraded the strength of the evidence for that conclusion to moderate. Maybe we were being too strict, but that's our practice. So I would maybe regard a moderate as a high in this case, if you want to look at it that way, but there were no conclusions for which the evidence was completely consistent in one direction.
So let me ask, so you're saying it's the ARC or the RAND policy to make that decision. That wasn't specific to the review for sodium and potassium, to move
Correct.
from
Right.
high to moderate with heterogeneity.
Right. And we would love to have been able to take the time to look at, for example, each of the blood pressure studies that actually saw an increase in blood pressure with some sort of sodium reduction intervention, but we simply didn't have the time to do that. For example, it would have been interesting to see whether each of those studies failed to control for use of antihypertensives or failed to do multiple measures of blood pressure, but we simply didn't have the resources to do that.
Okay, thank you. Larry, you want to make some?
Yeah, I want to follow up on that because I think, and you pointed this out earlier, Sydney, earlier studies, had methodologic issues. And I think one of the biggest ones, besides the measurement of sodium, is the measurement of blood pressure and getting adequate numbers of measurements. I've even seen recent studies where people get a single blood pressure measurement as their outcome. And that's especially when you're dealing with people in the non-hypertensive range, you're going to get a lot of variation. And our policy or approach in our feeding studies, and of course this takes advantage of the fact that people are coming in on a daily basis, is they get 5 sets of measurements and average them. So if you don't get 5 sets of measurements, you get 1 set of measurement or just 1 blood pressure, which is what happened in these studies. You're going to get variation, including variation in the opposite direction by chance alone. And that will also contribute to the lower strength of evidence because you'll have null results and results that are paradoxical. So I think methods are going to be really critical for this committee to dissect further below the surface of the review and say, what are the studies that are they fix sodium and they have high quality measurements, and hopefully they're of sufficient other quality, have other quality metrics to draw strong inferences.
So I'm going to follow up on that while we're thinking of it. So methodologically for blood pressure, what would you consider sort of the gold standard now, the cluster of 5 measurements at one sitting and time of day and instruments?
Sure.
So we have, if we were designing a study today, what would we like to do?
So it's this is one where there are. It depends on how precise the estimate is. I mean, if you in the confidence intervals you want around your point estimate, but the more blood pressures you get up to about 5 sets, you'll see a decrement in the standard deviation on change. So you get more going from 1 to 2, a little bit less going from 2 to 3. Around 4 to 5, you reach an asymptote. There's a paper by Vollmer that Journal of Human Hypertension that documented this really nicely. You could also use ambulatory blood pressure monitoring. My own sense is that ambulatory is one of the benefits is not the diurnal pattern, but the large numbers of measurements. There, people are active, but if you look at the standard deviation on change from ambulatory blood pressure, you get roughly what you would get with high quality 5 sets of measurements. By 5 sets of measurements, I mean 5 sets at baseline, 5 sets of follow-up to detect change.
Good. Let me ask one question while we have sort of both of you weighing in on this. So we all acknowledge, I think there's a good deal of controversy of what we're working on. But if you had to describe 1 or 2 elements that you think we have some certainty on, both for sodium and then for potassium, what would the 2 of you think our starting point is now for the committee's deliberation?
I actually think the sodium blood pressure relationship is strong based on the best available evidence. And that I believe is certain, and the ambiguity and that we heard based on a strength of evidence less than excellent, or whatever the term is based on weaker methods. And you can, I know that there are people of different opinion about sodium reduction, but it is the rare person that says sodium is not associated with blood pressure. Okay, it is the rare person. So I think that is fixed. I also believe that potassium with high but not as great certainty, and the reason for that is that we have, based on aggregate data, meta-analysis of best available studies, a blood pressure relationship. Higher potassium intake is associated with lower blood pressure. But we don't have what I look for. It's like, well, show me the best study, the one study that also shows that a diet or supplement, or a potassium supplement, is associated with lower blood pressure. And I try to look for that combination of, the best quality studies in a systematic review, plus the one sort of large definitive. The dose dependent is also is something that I look for, but those would be the two that
Sydney, anything to
I would agree with Dr. Apple, but based on the evidence, it's pretty clear that reducing sodium in an effective way, as he described, reduces blood pressure. It appears the evidence certainly suggests that potassium supplementation does the same, at least in populations with hypertension. Potassium does appear to have some adverse effects, which I didn't discuss. They're enumerated in the report. And there is also the issue of people with undiagnosed kidney disease.
Yeah.
Thank you. Questions? We'll do Patsy, and then we'll come.
To what extent do we know if baseline or usual sodium intake influences the response to intervention with sodium intakes? And I'm particularly interested in that with the new paper that you talked about that showed that the reduction in sodium is more effective in those with lower caloric intakes. And is this something that studies have considered sufficiently?
It's a great question. I think part of the problem with answering that is that you need to have an adequate estimate of usual baseline intake, which unfortunately we don't get. As we pointed out earlier, you need to have several 24-hour urines in order to estimate a person's usual intake or baseline. So I think that's the evidence. My recollection is not as strong looking at baseline, and I think that's in part because of, again, a measurement issue.
Hi, Wei-Shui Chu, Texas A&M. This is for Dr. Newberry. It's a methodological question related to your grading the evidence. I noticed that there is never, so in the usual grade framework, there's both down rating and up rating factors, whether it's a RCT or observational trial. But I didn't see any discussion really for the RCTs in terms of up rating for size of effect or dose response, for instance. And that I was wondering whether that could be part of the the apparent difference among systematic reviews in terms of the conclusions, and why maybe your review ended up at moderate versus other people thinking, well, maybe it's high. There's some of the judgments involved. Maybe you mentioned the uprating for the observational studies, but not for the RCTs. So I wonder if you could elaborate a little bit on that.
Sure. It's been common practice in the groups that I've worked with that when we're grading the evidence for trials, we start out assuming that the evidence is high, and then we downgrade for dings against that. So for example, inconsistency. Whereas we tend to, with observational studies, start with the very lowest level and upgrade if the evidence is better than we expected. We were particularly interested when we were looking at the evidence for the trials in dose response effect. And that would certainly have led us to upgrade possibly too high. Unfortunately, there are a very small number of dose response studies. DASH sodium is one of the only really 2 or 3. One of the dose response studies just didn't meet our inclusion requirements, criteria for reasons I won't go into, but we couldn't simply raise the strength of evidence based on the one study, although it would be tempting.
So did you,
if that answers the question.
just a brief follow-up, did you do meta-regression or anything like that to look across studies in terms of potential for dose response?
We actually didn't. I take that back. Back when we first started analyzing the data, we did meta-regressions on achievement of a decrease in sodium intake of 40 millimoles or more at follow-up. And one would think that any study that achieved a decreased intake of 40 millimoles per day or more would show a significant effect, but that was actually not the case. We ended up not reporting the results of those meta-regressions because they were done with a more limited set of data. But unfortunately, that was what we found. But of course, again, that's across studies.
I mean, there's heterogeneity, but whether some of the heterogeneity could be explained by dose response, or it might be obscured, but, due to the limitations that have been talked about already. Thank you.
Of course.
We have a question from Beth.
Larry, I wanted to ask you about looking at sodium-potassium interactions. You mentioned on the urinary excretion, the potassium is much more variable and you don't have complete recovery, so that would affect the ratio. On the intake, when you're looking at intakes for ratios, you've also got biases that may go in different directions for each nutrient. How do you recommend that we look at the sodium-potassium interaction?
It's a tough question. I know that, because I think that with the urine ratio, the one sort of theoretical benefit, if you have an error in collection for sodium and an error collection for potassium, you get the ratio and they eliminate it. So I have thought that at least part of the reason why sort of some associations with urinary sodium-potassium ratios related just to math, as opposed to biology. But I think there's also biology as well contributing, and that's perhaps more based on biological constructs. I think, experimental studies would be the best. I know that, the DASH sodium trial is not a test of potassium, but you can actually test for interaction, and you'll see that there is it's not a fully additive model. The effect of sodium plus the effect of the DASH diet, the combined effect is less than what you'd expect based on the average of each individual. So that's the cleanest, but we don't have many of those studies. I think statistical models where you have 2 variables like adding sodium and adding potassium are a possibility, but they're correlated. As calorie intake goes up, so do both of these. So I think they're really tricky. I'm not a nutritional epidemiologist, but I'm concerned about those kind of models. One thing that I like doing when somebody says look at sort of interactions is actually putting plausible levels of intake and excretion. Because some people say, oh yeah, a ratio of 5 or something like that, and then you plot in the what does it mean for somebody who's consuming, let's say, 4,000 milligrams of potassium, and it's like some outrageous number of the other nutrient. So it's tricky. I would prefer trials to answer the question. They're not that many.
Okay. I think it's clear from both of your comments and much of the previous work that blood pressure may well be a robust indicator.
Yep.
I'd like to ask, though, both of you, if you were to speculate on emerging or potentially other indicators as you advise the committee. Are there other indicators, both either for potassium or sodium, that, from your view, are rising to a public health roadworthiness?
Well, I can an indicator that is somewhat related, but we think of blood pressure, at this point in time. But I think more, I'm 62 now, so I'm thinking that the potentially the absolute best indicator for which we have even less data is the slope of blood pressure change with age, because if that were flat, in from child through adults, we wouldn't be talking about hypertension. So that to me is where all the action should be. Now, I can do these experiments where you assess absolute blood pressure change in 1 month or maybe 2 months, but and you might see relatively something, but if that effect is just incrementally occurs over time, you're going to have no blood pressure change with age, and the blood pressure epidemic is going to be greatly attenuated. So I really wish we just, doing those studies is very hard. I don't know of any clinical trials that involve behavioral interventions that last long enough to do that, but that's where the money is.
Okay. Sydney, would you make a comment about emerging indicators after working on this for the last couple of years?
I'm not sure I would be able to come up with other indicators, but I would agree that we really need to be looking at studies in younger people. I think that particularly in adolescents and young adults, and looking at the increase in blood pressure with age, as Dr. Apple said.
Okay, thank you.
Yeah, so this is also related to potassium, and one of the reasons why I said it's a shame that we didn't implement some of the research recommendations. I think the bone electrolyte, the effects of sodium potassium on bone is really interesting to me. I'm not an expert in this area, but I think there's enough, enough sort of experimental evidence with bone biomarkers that we should be thinking about osteoporosis and bone disease very differently from our current approach, which is fixated on vitamin D and calcium, and so that's one of the areas. I'm sorry if I offended any calcium and vitamin D people.
No. This is our stage today. Maybe one last question, and if anybody else in the committee has one, get ready because we'll close the session in need of the break soon. Please.
I have a question for Larry about your calories. Are there, besides the study you mentioned that's in press, are there any other studies comparing the sodium effect, say sodium corrected for calories versus sodium in terms of predicting either blood pressure or later events? And secondly, second part of this is, how would you implement this in labels?
Second part, that's your job, not mine. I know. No, I think that, nutrition communication is not my strong suit, but I think that we actually have to deal with the fact that most people do not consume 2,000 calories, and our labels do not accurately portray what people should be doing. I'm not quite sure what the solution is. Maybe there's, some electronic way that people can find out for their estimated calorie intake what they should be consuming. There have been some studies that have tried to do this. I think Jiang He here has done some studies in which sodium intake in NHANES, for example, was adjusted by calorie. The problem with those studies, though, and I think this is where a feeding study works out. We know how many calories are consumed. We know how much sodium is consumed. When you're dealing with observational studies, you're dealing with, you know, incomplete and over complete. And so the indexing by calorie is not done for as much, you know, looking is there a different effect by calorie level. It's looked at like, given that there is, you know, underreporting and overreporting, this is a way to like give an index of what is going on, trying to remove that effect. So I think the best studies are likely to be those studies where there was an experimental, it has to be an experimental intervention with reasonably good measures of both intake of sodium and estimation of calorie intake.
And on that note, we'll close this very helpful session. Thanks to both of our speakers.